Thank you. Although Phil has described us as a center focused at Columbia, we're actually an interinstitutional center that includes some speakers today, Avi Nath, Cindy Bateman, from your own area, Tony Komaroff, and then people on the West Coast as well. And we all work together collaboratively to address different aspects of within our own expertise. As Phil has said, the function of our center really is to focus to some extent on the role of infection and immunity in ME/CFS. And the rationale for this focus is that, as Avi Nath has just told you, there are a subset, very large number of patients who report some sort of a prodrome, a flu-like illness, prior to the onset of their syndrome. And we know from SARS and MERS and Ebola that severe viral infections can result in a disorder that looks like ME/CFS and may in fact represent it. And then we have many individuals who've had herpes virus infections, tick-borne infections and such, who develop something that looks very much like ME/CFS. And one of the challenges is that there are so many different presentations of ME/CFS that we're not really clear that we're talking all about the same disease. There may be a spectrum of diseases. That doesn't mean that we won't learn something that will be helpful for everyone, but it does mean that we need to break down categories. And that's one of the things that we try to do in our center. Our strategy has been to look at blood, feces, and saliva for bacteria, viruses, and fungi, using approaches that we've applied in outbreaks. These are very sensitive methods that allow us to find direct evidence of infection. We also look for indirect evidence of infection, exposure to bacteria, viruses, and fungi that may trigger the expression of antibodies, including autoantibodies. We're also very interested in looking at metabolic disturbances because we think that this accounts for many of the symptoms that we see in ME/CFS. And we believe this gives us an opportunity to find biomarkers that will allow us to diagnose patients. One of the things that's extremely important, even after we began the early work in this field, was to be able to go and say to individuals who are decision makers, clinicians, and others, this is a bona fide illness, and it moves us out and away from psychological aspects that many people were talking about for a very long time. There's no question but that this is a physiological disorder. And our rationale is that we will find abnormalities in metabolic pathways that underlie the symptoms and give us insights that will lead to diagnosis and prognosis. And our strategy is to survey the blood as well as other compartments for metabolites, proteins that differ in patients versus controls, and between subtypes of individuals with ME/CFS, including, as Avi Nath said a few minutes ago, sex-specific differences. We also find age-specific differences, which we believe are important as well. And there is the hope, of course, that this will lead to interventional strategies based on these insights that will allow us to develop treatments for people. One of the other things that we try to do in our center is to emphasize those sorts of stressors that lead to exacerbation of symptoms. The sort of Willie Sutton principle, the bank robber who was asked why he robs banks, and he said, because that's where the money is. So here again, what we're trying to do is to take those sorts of stressors that precipitate symptoms in individuals and then examine them rigorously to see if we can find explanations for their symptoms. So the rationale is that we're going to amplify those abnormalities. This makes it easier for us to detect and hopefully to understand them as well. Our approach has been to exercise patients and controls on a stationary bicycle. We then collect blood before and after exercise. We profile immunity and metabolism before and after exercise. And because we don't have access to tissues, we use as a surrogate peripheral blood white cells, which we can then expose to microbial stimuli. We have a clinical program as well. We're trying to identify clinical variants because we think that there's a spectrum of disability and there may be multiple paths to ME/CFS that will be illuminated by this kind of work. And this will allow us, we hope, to develop specific treatments, diagnostic procedures, and ways in which we can prevent disease. And these may be tailored to individual patients. Our strategy is to examine the database that's been built up over a period of several years using artificial intelligence to understand how we can integrate the signs, the symptoms of disease, as well as the laboratory findings. And Tony Komaroff has been trying to build an app for collection of symptom data in real time that's useful for both patients and their clinicians to track disease. We think this is going to be helpful in developing treatment strategies. And this app has now been turned over to SolveME, and they're working with this independently at this point. I'm not going to show you a lot of data slides because I think we're trying to keep this at a very high level so you can get a sense of where we're going, but I would like to highlight some of the abnormalities that we have found to date that we find are important and are already giving us the clues for clinical trials. If you look at feces of individuals with ME/CFS, and you simply look at the total bacterial load, as you can see on the left side of the screen, individuals with ME/CFS actually have more bacteria in their feces than their age and sex matched controls. But if you look at the composition of those bacteria, what you find is that there's a reduction, as indicated by the arrows, in a specific set of bacteria that produce a compound known as butyrate. Now, we've not just rested with characterization of bacteria, we've actually then measured levels of butyrate. So in this slide, in the left panel, you can see that not only the bacteria that are capable of producing butyrate reduced, the actual amounts of butyrate in feces are also reduced. I don't have time to go into the CNS abnormalities associated with low levels of butyrate, but we know that butyrate is extremely important for supporting GI motility, and this may explain why some individuals have difficulties with irritable bowel syndrome. It's also anti-inflammatory, it controls pathogens, and it controls the intestinal barrier. This is very important because it means that toxins that might be present that would normally be excluded can now passage into the systemic circulation and cause disease. Using a method called proteomics, we've examined the expression of proteins that are present in the blood of individuals with ME/CFS. And what's been most striking to us here is that there appears to be an expansion of specific populations of B cells, the same sort of expansion in their numbers that you would see in an infection, bacterial or viral, or an association with some sort of an autoimmune phenomenon. When we initially reported this, we really weren't able to get into what I would consider to be the highest profile journal, but subsequently, there was another group that independently confirmed these findings. This is extremely important. As Professor Nath noted earlier, one of the challenges here in this field is that we don't have the sort of reproducibility that's required. We're beginning to see that as more and more people are doing similar types of work. The implication of the finding is that we may be able to find and eliminate the trigger, and that in fact may result in an improvement in disease. I mentioned the sort of Willie-Sutton principle of trying to bring out the abnormalities with exercise. So using exercise stress testing, we have been examining findings in the immune system as well as metabolism in association with exercise. And what we've learned is that patients with ME/CFS have a heightened inflammatory response after exposure to the yeast candida or to bacterial extracts. The sex-specific effects and inflammation are profound. So we see higher responses in women than in men, and that effect is particularly great after women are 45 years of age. We've also looked at metabolism, and I'm just summarizing one of the most interesting findings here. So there are in the mitochondria various pathways that are used to process compounds to give rise to certain energy molecules, which are critical for central nervous system function, for muscle function, for any sort of physical activity whatsoever. And the cycle is shown on the left side of the screen. It's called the Krebs cycle, or the tricarboxylic citric acid cycle. And what happens as you spin around through this cycle is that these individual compounds are metabolized and ultimately they wind up giving rise to high energy phosphate molecules. If there's a backup in this system such that the circle can't proceed, you get an accumulation of backup of some of those other molecules. And the red arrow there indicates the presence of citrate. Now, if we look at blood that we've collected from individuals who've exercised, who are either normal individuals or individuals with ME/CFS, if you look on the right side of the slide at the pre-exercise test controls and the post-exercise test controls, you can see that the levels of citrate are the same or, if anything, down. In contrast, on the left side of that slide, with the red rectangles as indicated by the red arrow, you see an increase in citric acid, which suggests to us that that cycle is blocked. And this may, in fact, give rise to problems with energy metabolism. Using these kinds of findings, we're beginning to develop models in which we think about ME/CFS. Our notion at present is that there are individuals who are predisposed for whatever reason. We don't fully understand that. That's going to require genetic studies, and various trigger factors, which may be fatigue, injury, immunological stressors, including infection, result and manifest in what we see as ME/CFS. So the question then is, why might this happen in some people but not others? The approach to this, which is the one that Professor Nath talked about a few minutes ago, is to try to look at genetic factors, to look at transcripts, to look at DNA, to look at small RNA molecules, large RNA molecules, to characterize cytokines, which are the molecules that are associated with inflammation, to look at the microbiome, and to study other factors as well. And presumably, as we do this, we will begin to understand not only fatigue and the prolongation in the recovery time, but some of the abnormalities we see in the nervous system, such as the inability to maintain blood pressure, Pott's disease, brain fog, or the peripheral associations like pain, which you've also heard about. So in the last year of this 5-year award that we have through the generosity of the NIH, we're focusing on the following. We have done most of our direct searches for infectious agents. There's a subset of individuals who have herpes virus infections. I've already showed you that there are abnormalities with respect to the fecal microbiome. We think that many of these infections that would be of interest in terms of triggering the disease may no longer be there. So it's a sort of a hit and run model. Our approach, therefore, is to use antibody tests to look for evidence of infection. And our hope then is that we can identify those that vaccines or drugs may modify the course of disease, and that can be tailored to the specific type of infection. And there are individuals who have benefited from the use, for example, of anti-herpes virus drugs. I think that that's likely to be a small percentage of the population, but nonetheless, people we need to identify. We want to identify genetic marker for susceptibility to this disease so we can identify and protect those at risk. And as we get more and more basic science data, we hope to be able to build animal models based on those findings so that we can test potential interventions in a safe fashion. The other thing that's come about really as a function of the pandemic, the silver lining, if you will, though it's hard to think of it in those terms, is that people have begun to look at other kinds of disorders for evidence that might be helpful in illuminating what's going on in ME/CFS and vice versa. One of those, of course, is long COVID, and I'm deeply appreciative of the efforts of this organization as a founding member of that effort to try to focus resources there. Another is Gulf War illness, and I'll be coming back to that in a moment. And the idea here is that we will find similarities and differences that illuminate pathways to cures. This Venn diagram illustrates some of the similarities between ME/CFS, Gulf War illness, and post-COVID. And as you can see, fatigue, muscle joint pain, and headache are common to all three. Now, for those of you who don't know what Gulf War illness is, this is something that occurred in veterans who participated in the Gulf War, and they had multiple antigen exposures as a result of having sometimes as many as 10 or 14 vaccines in a very short period of time. They also are exposed to various neuroactive agents. So this is something that's never been solved, and we're hoping that by looking at these different disorders in parallel, we will learn something that will be helpful. We were asked to talk about potential clinical trials. I think one of the things that I would be most excited to try to address would be to identify those individuals who have very low levels of butyrate producing bacteria and find out whether by using prebiotics and probiotics, which are really fairly benign, whether or not we can show some sort of an improvement in symptoms. And here's where the app that Tony and SolveME have developed will be very, very helpful in tracking how people perform in their activities of daily life as a function of those sorts of treatment protocols. We also want to see if we can find individuals who have activation of herpes viruses that we have not yet been able to detect using direct methods like polymerase chain reaction or sequencing. If they have increases in antibody titers, this might allow us to try antivirals. Again, the nice thing about the anti-herpes drugs is that they're really relatively non-toxic. And as we begin to understand something about the metabolomic pathways that are abnormal, we think that there are already drugs we've identified that can be used to modify these pathways, and hopefully some genetic methods like CRISPR as well. Thank you very much, and I'll be happy to take whatever clarifying questions Vicki wants to pose. Over.
Thank you, Dr. Lipkin. Yeah, I have a couple of questions here for you. So you talked about the differences that you found between men and women and by age. Have you also looked at differences by duration of illness?
So a few years ago, when Mady Horning and I did cytokine studies, we found that there was a difference in individuals who had had disease for less than 3 years or more than 3 years. And there were dramatic differences. It almost looked as though after 3 years, people began to burn out. So we've not done a similar kind of analysis with the exercise stress test because we don't have a large enough representation of people who have short duration illness or long duration illness. But it's a very good question. The other thing that I can't tell you, just sort of anticipating another issue, we don't yet have any estrogen data. So there are differences in women who are more or less than 45 years of age. And I expect that this may be important as well.
Interesting, thank you. And then another question about any clues on how the presence of only IgG could cause the illness and the variety of symptoms. And sort of part two to that, is it possible the symptoms are caused by more than one reason, more than one thing in any individual with ME/CFS?
So to take the first question, initially, the idea is that there seems to be a clonal expansion of specific, let me change that. I'm already lapsing into jargon. There seems to be an expansion of particular populations of B cells that typically follow some sort of antigenic stimulus. We know that people who have elevated levels of immunoglobulins are more likely to have autoimmune disorders. We may find that there are cross-reactive antibodies, something that's triggered by an exposure to an infectious agent, which then results in an autoimmune disease. I don't have any evidence yet. That's purely speculative, but that's something that we are trying to approach by using some sophisticated molecular methods that I think will give us an answer within the next 6 to 12 months. Now, the next question is, could there be several things that work together to cause ME/CFS, or could there be different pathways to ME/CFS? Yes, I think that is the case. I think that you're going to have to find ways in which you can pursue precision medicine and precision science, because there's a final common pathway that we know is ME/CFS, but some people may have this as a result of exposure to infectious agents, others to toxins, other to exposure of autoantigens. There's a wide range of possibilities.
Thank you very much for that. One more question here. What are some of the theories of what causes the microbiome changes? Is it exposure to antibiotics, differences in viromes, inherent differences in gut immunology?
So we're getting very deep into the weeds now. And, I can't even say for certain that the changes in the microbiome are a function, are in fact what triggers the disease. One of the things that we really need to do is to examine the microbiota, the microbiome of individuals who for other reasons have fatigue, people with congestive heart failure, people who have, who are paralyzed, what have you. There may be a wide range of things that lead to these changes in the microbiome. That said, it's still possible that even if that isn't the original trigger, it may exacerbate disease. And the only way to approach that is going to be with what we call a randomized controlled clinical trial. And I think that given that this is really not a risky sort of an approach, you can simply drive up the right types of microbiota by using large amounts of Metamucil, for example. This is something that would be a great opportunity for us to test that hypothesis.
Thank you. Yeah, I know there's a clinical trial, a fecal transplant clinical trial that's been planned in the UK that was put on hold because of the pandemic. So I think, there's some very interesting questions there. Absolutely. All right. So I think with that, thank you, Ian, and back to you, Phil. I think we'll move on.
Okay. Thank you, Dr. Ian, Dr. Lipkin. That was very informative, and really appreciate this work.